Good morning, everyone. Hi. Thanks. I think we are okay. I may need your help at the end with the video. So come back closer to 8:45 or so. Okay, I've got a short video at the end, which is very important. So anyway, as you can see on my introductory slide, that I hope to take you for a walk with Dorothy and her merry companions along this yellow brick road. The primary purpose, some of you seniors must be wondering, we know everything about Billy, why is he talking about it? But as we will see, there's a lot of some new information. There are some danger zones as we walk through the Wizard of Oz book, though most of you may have read it, being pediatricians in this audience, that there are some scary moments which we'll see with Scarecrow and Lion down here, and hopefully you will gain some new knowledge. But the major reason for my presentation is your chief. I had given her several topics a few weeks ago. She thought that this is very important from a pediatric exam point of view, because she had a number of questions in this particular area. So I was trying to see who are the seniors sitting at the back there. Let me put on my special Wizard of Oz glasses here. So now that all of you are awake, I can see where you are. So I will quiz you. Oh, you found it? Thank you, sir. I'm sure now you can hear me better. My kids always tell me I'm speaking too loud, but I tell them the first thing to go. So anyway, getting back to today's talk, I do not have any disclosure or conflict of interest with any commercial ventures, and I will not be promoting any unapproved products, although, as I will allude to, as you saw in my introductory slide, the Tin Man that is on the doorsteps of the FDA to be approved as a new prophylactic treatment for this condition. So, as usual, I have here the objective, the 6 objectives. Some of you must be wondering, why is this guy talking about history to us? But those of us who are from the dinosaur era, as you know, those who forget history are doomed to repeat it, as you can see on my 5th bullet point here. It is very tragic. Some of us started our research career in this field and found the problem was solved. Lo and behold, this had recurred with a vengeance, as we'll see at the end of my talk. And finally, we will list some of the therapies that are in the horizon, some of them that are established. So moving on to history right here, as you can see, it dates back to more than a century here, starting with a German pathologist here by the name of Schmoll, who coined this term, Kernicterus, 2 separate words. Kern is a German term meaning basal ganglion, and icterus is a Greek term meaning yellow staining of the nuclei of the base of the brain. That's why the term. And again, it is a pathological term. People have wondered, why has there been a hiatus for almost half a century? Anybody wants to speculate? Most neonatologists or experts in this field feel that this was hidden in obscure pathology German manuscripts, so that's why it was not. But my contention is a little bit different. You notice there's a flurry of activities in the late 1940s and early 50s. The reason for that, in my humble opinion, of course I'm not very humble all the time, that as some of you know, Dr. Vandenberg, who described bilirubin measurement, he was a Danish chemist, biochemist, direct and indirect bilirubin, did not describe it till the early 1940s. So that's why I think it was. And again, as Dr. Bucchini, our boss, knows that pediatric did not exist as a subspecialty. There were internists at different parts of the world who were interested in babies, taking care of them, and babies were dying of Rh hemolytic disease of the newborn. So today we take for granted that we put in UVCs, USCs. It was not placed till the late 40s. And lo and behold, the big study from Mass General or Harvard University showed that you classify into 3 different clinical groups, those babies who had a bilirubin of less than 20 milligram per deciliter had a much lower incidence of Kernicterus. So that's how that number came to exist. However, we as pediatricians misuse it. Do note that this number was used for arrhythmia, with the severe hemolysis. It does not apply to all other causes of jaundice, non-hemolytic particularly. Around that same time, there's a drug, Dr. Bucchini knows this, perhaps history, very fascinating, called gantracin sulfasaxazole. The father of modern neonatology, Dr. Bill Silverman, the very first NICU in this country at Columbia University, was doing the first randomized controlled trial where in those days they were giving penicillin and streptomycin to treat sepsis. So the new drug called sulfasaxazole came in, so they randomized in 2 groups, and he had a very smart chief resident like you, Sarah, so who went and looked at pathology and found that babies in the sulfasaxazole arm who were dying had yellow staining brains like that. And a few years later, my ex-boss, Dr. Jerry Odell at Johns Hopkins, introduced the concept of bilirubin albumin binding. We'll briefly talk about that. And again, after a hiatus of approximately 10 years, ROGAM was introduced. It's a story by itself, but I won't go into the details. As some of you may know, this drug would not have existed if it was today's area of research, because it was tried at the prisoners in Sing Sing by the NYU immunologist and hematologist who were looking at the antibody reactions. So nobody, in those days you could do trials in prisoners. Another decade later, a major breakthrough, which again took some time to come to this country, Italians and Europeans were using it for some time, is phototherapy, which literally markedly decreased the incidence of brain damage due to Kernicterus, and many of us were looking at other fields like surfactant or neonatal pulmonary diseases, but to our great surprise, Kernicterus came back with a major vengeance. Does anybody want to speculate why? What are the 2 reasons? And we are the reasons, we as physicians, directly or indirectly. What are the 2 things that happened between 70s and 90s? In other words, in the 1980s. Early discharge. Very good. Excellent. Early discharge. The American Academy of Pediatrics insurance companies said, we can send them. The AAP also did a mistake, of course not really a mistake, is promote breastfeeding. So when you got young mothers without family support, you're sending them home on day 2, as we will see from some of the data I'll present to you subsequently, the incidence of Kernicterus shot up rapidly. And so with that, let's go back to the basics, starting with the fetus. As you'll notice on this slide, there's almost 150% increase in bilirubin production in that growing fetus. And this is your board question, guys. 30 weeks, you have 1/10 less production of glucuronidase transferase. The second reason is fetus has increased beta-glucuronidase activity. This is an enzyme that's present in the upper part of small intestines, as we'll see, which increases that intrahepatic reabsorption. So the question for the smart residents at the back is, what could that cause Kernicterus, that high bilirubin production? Anybody, volunteers? Any damage? The answer is yes or no. No. And the reason for that, like Mother Nature, our mothers do the work by disposing of that bilirubin through their placenta, as I'll show in the next slide. This is a cartoon of bilirubin excretion antenatally. Here's your placenta, the fetal compartment on the right side, and the maternal on the left side. Notice the bilirubin that's produced, bound to albumin, crosses actively to the mother's side, and her liver conjugates it into the bile and gets rid of it. So therefore, it's very unusual to get unconjugated bilirubin in the umbilical cord or in the brand new newborn baby. Okay? As we said earlier, there is a developmental production of glucuronidase transferase, as you see on the vertical axis, along with gestation. There's a 10-fold increase, as I said, between 30 and 40 weeks. Again, that's your board question. Thereafter, there's an exponential increase, so therefore neonates are one of the reasons neonates are at increased risk for jaundice. As you know, 80 to 90% of them are. So where does this bilirubin come from? As all of you know, this is a tetrapyrrole, iron with an iron moiety in the center, alpha, beta, gamma, and delta chains here. So and this is very important. Some of you must be, I see somebody yawning already. No, I'm just kidding. Some medical students. This important enzyme, it's a very important enzyme in many cells of the body. But here in the hematopoietic system, it oxidizes to this water-soluble green, just like my glasses I just wore, to a greenish yellow water-soluble compound called biliverdin. And I want you to hold that thought for a moment in the back of your mind, and I'll come back to it in importance, or quiz you on what is the importance of that. Thereafter, it's reduced by the enzyme bilirubin reductase to form this toxic product, bilirubin at very high levels, and we'll talk about its conjugation a little bit later. So coming back to this, as you can see, once you're oxidizing it, the iron moiety is removed and carbon monoxide produced here. And this is some smart neonatologists and physicists and chemists came up with an idea, which is one of the breakthroughs in the treatment here. Does anybody want to speculate what it is? Or say, if you know the fact, it is a fact. There are clinical trials documenting it, and these treatments are well accepted in Europe and other countries, but the FDA is still looking at it. So you replace this iron moiety with another synthetic substance that would not allow this chain to go further, therefore you're not producing bilirubin. The reason FDA has not yet approved that is because, as we will see, bilirubin is a two-edged sword. It's a little bit is good, a lot of it, like many things, if you get drunk on a Mardi Gras, you get bad, so a little bit of alcohol is good for you, right? He knows that, I'm just kidding. So, sorry boss, okay. So what is this bilirubin? It is, chemically, those of us who investigated in the lab or the bench before, it's a very complex and unstable structure. It has intramolecular hydrogen bonding. So as you can see, this is a paperclip analogy, and in this three-dimensional molecule here, the water-soluble compounds are internalized. It's like a ZZ, we call it, and the 4-carbon and the 15-carbon, there's a Z form, and it is not at all water soluble, it's highly lipid soluble. That's why it binds to the lipid membrane, whether it's in your subcutaneous tissue, skin, or the brain nuclei, and causes damage. So that's the structure. And again, as I said, it is unstable, converted to many other isomers. We will briefly allude to that later. Now, again, to summarize, this is your board question. Most of the bilirubin is formed from the breakdown of the red cells. Right? We know that neonates have high red cells. Medical students there, why do they have high red cells? Why did Mother Nature convert such high red cells? Because you need to carry that oxygen in the fetus to the tissues, right? So RBCs have a much higher concentration. Normal hematocrit for a baby is 45 to anywhere between 45 and low 60s, right? So those red cells again would break down and produce that heme. Again, please remember, I don't like numbers. You can always look it up, but this is your board question. 1 gram breaks down to 34. Okay, this is another board question, because I looked up several questions. Neonates produce 2 to 3 times the amount of bilirubin that you and I produce here. So keep that. And why is that? As I just said, they have a larger red cell mass in utero to carry that oxygen, which breaks down because of a shorter lifespan, 70 to 90 days, as opposed to 120 in us, produce that heme and the pathway I talked about earlier. So again, to summarize here, that heme is breaking down, oxidized, reduced to bilirubin here. In the process, you are producing carbon monoxide and bilirubin. And some of my colleagues at Stanford have, I'm sure Dr. Wilson knows, David Stevenson made his career out of measuring carbon. This carbon monoxide is bound to hemoglobin, recirculated back, excreted in the lungs. If your lungs are normal, that is a measure of the severity of hemolysis. They have developed equipment that can measure that. So you can know how badly your baby is hemolyzing. Also, they took it a step further to look at treatment, how that carbon monoxide measurements or carboxyhemoglobin levels have altered in the treated patients. So now once that bilirubin is formed, that is bound to the serum albumin, this is a cartoon of a hepatocyte, is accepted by the receptor protein, the Y and the Z proteins to keep it simple, in the smooth endoplasmic reticulum of the liver, conjugated by the enzyme glucuronyl-transferase, primarily to monoglyceride, but a little bit to diglyceride. But fetus is very unique in the sense that it has got this enzyme we talked about, bilirubin glucuronidase, so it's deconjugated, so that water soluble becomes lipid soluble again and is reabsorbed. Oops, see that I had a seizure there for sorry about that, guys. But anyway, this is your board question. If they ask you what is the major cause of physiological jaundice, the answer is enterohepatic. Again, Dr. Jerry Odell, God bless his soul, the chief of neonatology at Hopkins, described this by giving what? Does any neonatologist know? When we were residents, he was giving agar. He studied agar, and this was Japanese agar from the Japanese weeds. And he could show the bilirubin go down. So it's mainly from the gut, right? And it was being used in treatment in Japan and other countries at that time. Anyway, for you as a budding pediatrician or a physician, or those of you who are going to be surgeons, I can see some med students, I'm kidding. You may have relatives whose babies are jaundice, so you must know these topics. The question is that yellow baby is physiologic or pathological? Most of the time, I see even on rounds, residents see a bilirubin, they put phototherapy, but you don't want to miss that rare pathological causes, and we will allude to that very shortly. But again, as I said, most babies are jaundiced. Why did Mother Nature make most babies jaundiced? Anybody? Louder. Come on, pretty girl, huh? No? It's a potent antioxidant, okay? When people had nothing to do after phototherapy in the 80s, they were investigating that, both in vitro and vivo, and Dr. John Stocker first described that. There's a physiological importance. He's a physicist at UCSF who wrote some elegant articles on it that is very good for you. And that's the reason the protoporphyrins are not approved, because they think if you block that heme oxygenate by giving other protoporphyrins such as tin or zinc, you may not produce enough bilirubin, which is good for you. But again, I think it's a theoretical argument, because there are clinical studies from Europe clearly documenting its advantages. Now, let's spend a few minutes, as I said in my objective, about physiological jaundice. This is a slide with the age on the horizontal axis, total serum bilirubin, and which all of you, when you make rounds in normal nurseries or deal with neonates, you'll see that it rises between 3 to 4 days of age. And here it is. These babies are formula, are bottle fed. This is how the peak. Again, you can see there's a standard deviation. As opposed to that, as you know, we try to promote breastfeeding, and you must try to do that. The curve is shifted to the right. There's a higher concentration. Here's a bottle fed in the gray zone. Here's the breastfed in the orange. As you can see, they can go as high as 16. So again, it's important, and I will talk about it very briefly later on. So what are the things that tell you this is not a physiological jaundice? If your baby is jaundiced in the first day of life, if the rate of rise, again, these are arbitrary criteria, greater than 5 milligram per deciliter, if the total bilirubin in a term baby is more than 13, breastfed or a premature more than 15, direct acting bilirubin is more than 1 or 2 milligrams or 2% of the total, jaundice lasting more than a week in a term and more than 2 weeks in a preterm infant. A bell should ring in your head. Let me examine this carefully. All right. You know me, I love to kiss you out. No, just kidding. We like to keep it simple, and I'm a stupid guy. No, just so every day when you get up, think of the faucet theory when you look at a jaundiced baby. What is being produced, as we saw, what is being eliminated. Very simple, right? So we will talk about pathological causes, allude to them briefly. So if you look at the production, or if you open that faucet, we talked about RH has mostly been abolished. In some countries, certain provinces in Canada, certain countries in Europe, it doesn't exist. Japan, they literally screen every girl. And if it's an RH negative, they'll follow through that because of the healthcare system. They'll give an anticoagulant for RH negative. So it's literally the disease has been abolished. Whereas when I came here, we occasionally still see it, but it's a devastating disease, those of us who've seen it. So the main disease you will be facing as a pediatrician is abiohemolytic disease, and we'll briefly allude to that. There could be a number of heritable problems, which could be the problem in the membrane, the enzymes of the red cell, G6PD, pyruvate kinase, and other enzymes, could be in the hemoglobin itself. This is an arbitrary classification I've made. The other causes of increased production is sepsis, Dr. Bocchini's favorite area, right? This is something we never forgive somebody. It could be bacterial, it could be viral, enterovirus, other adenoviruses, it could be herpes is the most important one. When in doubt, treat that patient. You cannot delay the diagnosis. One we often miss is extravasation or extravascular hemolysis of the red cell membrane, and some of the causes are listed here. Nowadays we don't see polycythemia anymore, but we are seeing an increase in diabetes baby. So one side faucet is open, the other side that there's a block in the clearance system, and that is what I have different causes I've listed here. We talked about intrahepatic circulation. It is thought today that breast milk jaundice is one of the major causes, though I will present you some data that says otherwise. And it's a very new data that's come out of Japan. Decreased clearance in premature babies, and again that's a problem in G6PD. Reason I highlighted in green here is several studies from other parts of the world and US have shown that we miss a number of patients with G6PD as different populations are migrated from different parts of the country. So keep that in your differential diagnosis. And I have this in red because these are diseases you don't want to miss. On the inborn errors of metabolism, fortunately for us, we claim that we do screening of newborns, but remember by the time you get screening results, it's a little too late, and there are plenty of studies, as the CDC and other agencies have looked at. There are false positives, false negatives, so one has to be very cautious there, and certainly endocrine causes. So one of the breakthroughs at the turn of this century was the identification of this gene, the human UGT1 locus, with the genomics that have come out. And as you can see, there are variable exons, which has classified the alanine glucose transferase 1 gene, which is important in a number of conditions we will allude to, and they are mainly Criggler-Najjar, Gilbert-1, and newer gene therapies and all are being developed. But suffice it to say, this is the promoter part of it, and this is the wild type of TA, and this is heterozygous. So there are a lot of different genetic variations, if you will. So getting back to breast milk jaundice, because you as pediatricians are going to promote breast milk jaundice, let's look at it a little bit here. Well, the incidence has been described in most textbooks between 10 to 13%. So 1 out of every 10 babies will get that. It comes in a little bit earlier, 2 to 4 days, but as we said earlier, sometimes you discharge, and if you, those of us who do pediatrics in other countries, many countries discharge babies within a few hours after birth, or there are a lot of home deliveries. So it's very easy to miss that. The bilirubin peaks, as I showed you earlier in my graph, 3 to 6 days, curve shifted to the right in breastfed versus bottle. Cause, if you're asked in the board question, increase intrahepatic. Decreased fluid calorie intake. Some of you may have seen babies coming back to the hospital with readmissions because of that reason, and poor feeding practices. Whoa. So again, management. In the old days, we used to say, give a lot of glucose water, right? Dr. Bocchini probably remembers that, but we don't do that. So no. Dr. Bienvenu will teach you, put the mother and the baby together on the breast. When I travel around the globe, I go to the NICUs and normal nurseries. The mother, right from the time of birth, the baby is on the mother's belly, between the breasts, and suckling there, so we continuously do that. And my own daughter has also done that. So that is a major cause, a major way to increase the breast milk flow, and you don't worry about the little bit of jaundice, and we'll talk about it. So as opposed to that, there has been a syndrome of breast milk jaundice syndrome, which is very rare, commonly seen. I first saw my cases when I was in Arizona in the Navajo Indian tribes. It's been described in Alaska, certain other ethnic groups, and so on. So this is less common, occurring to 2 to 4% of the babies, and has a relatively late onset, as you notice here. After the early jaundice is 2 to 4 days, is 4 to 7 days. Again, these are arbitrary classification, and as I showed you, it may not peak way after when he comes for your first visit in the clinic and the follow-up office visit, and it can last for up to 2 to 3 months there. So that's very important. The substance has been controversial. There have been many experts in pediatrics who have described different compounds, pregnantiols, sterols, fatty acids. So nowadays I'll present you some data on genetic aspects of it. The babies may look well, but they can go, some babies rarely can get into trouble, as we'll see. There's a very recent article came out a couple of months ago from Japan. Fascinating studies. What do you see here? So they have looked at gene mutation in breast milk jaundice. The total bilirubin, the mean serum bilirubin is plus minus standard deviations listed here. 4 months later, they're normal. Fascinating. The same gene we talked about, one of the alleles, in both the alleles, they are abnormal in half of these cases. Again, as I said, the article just came. We're just touching the tip of the iceberg here. Perhaps this is a different subgroup of populations they feel in Japan. Again, the same cannot be translated into our population, something to keep in the back of your mind. This is hot off the press. And this is something I want to share. When I was young faculty, a fellow, a resident like you, we thought Kernicterus doesn't occur in breastfed jaundice. I will allude you to Jeff Mazels' article where he did a survey. Babies between 4 and 10 days had anywhere between 40 to 50 milligrams. Some of them had classical Kernicterus. So it can occur. We don't know whether these are inhibitors because they are retrospective patients that have been pulled out of databases. So I said I'll touch on a few disease states, ABO hemolytic being the commonest condition you will encounter here, wherein the mother is O positive. So what happens to an O positive mother? Any resident? So those mothers have naturally occurring antibodies, anti-A and anti-B, right? So they will cross from there to the fetal compartment. They're IgG coated, and they may cause hemolysis. So how do you diagnose that? Increase unconjugated bili, you will have Coombs test that is positive, and baby's blood time, I forgot to put the Coombs here, and the peripheral smear may show some spherocytes. I'll again show you that. There may be increased reticulocytes. The management, of course, as you know, you want to follow. If you see the mother, Dr. Bienvenu may remember, right? At one time, we were routinely doing the blood type of babies of all O positive mothers. Correct, Dana? But we've given it up now. But something you want to ask that mother. Now we don't do it, right? At one time. That's why I said history, past, we were doing it. You don't have to do it. Studies have shown you don't have to do it. But you have a high index of suspicion in a mother who's had a previous baby with jaundice, who's O positive. So that's where you would follow that baby carefully. And the management is very simple. And again, people have, it is not all benign. In this condition, you can, as you can see, some of the data is from developing countries or Africa, that there is a significant Kernicterus in these babies. So and there is a number of papers that looked at it. And we think in US and developing countries, Kernicterus is gone, but it has not. And I'll present you data very shortly. Moving on in the interest of time, one of the diseases we dread to see is Criggler-Najjar syndrome. It's very, very rare, occurring over 1 in 200,000 or less. But it is transmitted autosomal recessive. In cases, though, there could be different homozygous, heterozygote. Again, the EGDP gene is mutated in some of these patients. So counseling by you as a pediatrician is very important. As I again said earlier, some of these babies can go to high bilirubin level causing Kernicterus. The parents can have partial defects, so you must investigate. Very often we forget to investigate the parent. and you can do a liver biopsy to look at UGT. There are genetic ways of diagnosing it. The treatment of choice currently is partial or complete liver transplantation, though there is some very good papers on hepatocyte and transplant and gene therapy. I won't go into the details, but I'll be happy to give you references later. As G6PD, I said earlier, many people miss that as a diagnosis because populations from different parts of the world have migrated to Europe and here, as you know, so we don't often think of it. So in the US, it's estimated 4 to 7. In the Kernicterus registry that's maintained in Washington, D.C., it's estimated to be about 20%. It is an X-linked condition, as you will see. So you've got a male baby, think of it. It's got different genetic origins. There are a lot of different genotypes here. And whenever you have a patient from Mediterranean, those of us from East India, you have to have a high index of suspicion because they can have very severe, many of us have seen severe hemolysis in these babies. And again, this has been identified in the gene polymorphism. Again, screening tests may pick it up, the number of them that have been described, and again, you want to treat them as early as possible. So, you see a jaundice baby in the normal nursery, you're busy, got tons of babies to see. So very least you should do is what is listed in the top 5 bullets. Get a history, and my best people are family practice or first-year residents who take that history, they look at the baby, they've examined the baby for jaundice, pallor, hepatosplenomegaly. You have to find out the mother's blood type, and I will emphasize, this is very important, those of us who are from the dinosaur, not you, but me, from the dinosaur era, were taught to look at the peripheral blood smear and look at the reticulocyte count and then nomograms for each day, each race of babies. And of course, as Dr. Bucchini and McVie will tell you, that if you think the baby is sick, you cannot afford to overlook the diagnosis of sepsis or metabolic endocrine disorders. So in terms of what are the red flags, danger signs, family history, you've got jaundice first 24 hours, first 3 days of life, or after first 3 days of life, as I described before. If you got these symptoms, again, those of you senior residents can see these same things. You'll see a number of diseases, including infection. But what I'm highlighting here is these are the early signs of Kernicterus. If you're not aggressive in your treatment, because there is good data suggesting you can reverse it at this stage. But if you wait too long, God help us, as we'll soon see. And what does these last 2 things tell you? Anybody? That you got a conjugated bilirubin, right? You got dark urine. We rarely see it, and I'm not going to talk about conjugated bilirubins of premature babies today. One of my ex-attendings, Dr. Kramer, described this. Some of you are familiar with my friend, Billy. As you can see, dermal zones of jaundice progresses from the head to the toes. If you got above the belly button, you got about 10 milligram. If it is below the belly button, we used to do a serum bilirubin in the old days. Of course, you're in trouble if the hands or the feet are jaundice of that newborn baby. But nowadays, thanks to our Japanese colleagues, they have made it the state of art using transcutaneous bilirubin ometers. And again, it's been correlated with clinical zones, and we'll briefly talk about it. Again, there is a reasonably good correlation in this on the earlier excellent studies with R of 0.91, it's transcutaneous serum bilirubin. But notice that most of us would not rely on it beyond 10 milligram per deciliter. So again, some people ask the question, is it reliable on a dark pigmented baby? Yes, it is in this study and several. Again, it's not absolute. The other thing, as I was explaining some of my residents earlier on rounds in the week, that people forget simple things, and that is we are maybe comparing apples and oranges. Those of us who've worked in this area, we will briefly look at the bilirubin movement in the different tissues that you're comparing in the skin or subacute tissues with the serum. So you're bound to get different. It's not an absolute number. And there are problems in measuring bili, which I'll allude to very shortly. And in the interest of time, I'll go through that. This is a very recent paper from Europe where they have used, those of you who are ladies, do your makeups and all that, they have used the same technology to look at skin pigmentation on your left is the baby light colored or dark colored. As you can see, you don't have enough light colored here, but there's a pretty good sensitivity in terms of the medium and the dark colored babies here, and the negative predictive value is pretty good here, at least in this study. So the other thing I often am reminded by some resident, oh, this kid has been on phototherapy, we can't do a transcutaneous. Hello? No, you can. Again, you have to think that for that baby, you have to develop a nomogram. What is the difference post-therapy in the transcutaneous versus a serum bili? And again, it depends how you're doing the serum. Heel stick versus free-flowing blood. There could be different numbers easily by 2 milligrams. So what this paper shows you, a very nice paper, it just came out a year or two ago, 2.5 milligram less. So you just add that number. So if your baby is coming close to 8 or so instead of 10 or 11, 9, you go and do a serum bilirubin. You don't have to do it. I personally recommend you do transcutaneous. Very easy, very simple, very fast. But again, you have to train your staff, just like pulse oximetry, as I told you all before. So again, this is Dr. Bhutani's curve. Most of you are familiar, so I will go very, very quickly over it. On the horizontal axis, you have age in hours. Vertical is total serum bilirubin. He arbitrarily classified that into 3 or 4 zones. Low risk zone, in low intermediate, high intermediate, and high risk zone. But again, notice in his high risk zone, he's not going above 70, 95th percentile, right? So here's the low risk, yellow. So if you, in the first 24 hours, you're discharging early, 5 milligram. Again, this doesn't guarantee anything. But if you've got a bilirubin that is around 10 or above, you better not discharge that baby, okay, till you got another number to two, because you want to see that trend. Again, we are talking about non-hemolytic disease here, okay? So these were the conclusions they drew, that they are, this is the actual data. I mean, as I said, they were only looking at 17 and above, very close to 17. They had no patients in the almost 1,800 babies in the low risk zone. They had 2% in the babies in the low intermediate. It jumps up to 13%, and notice what happens. It jumps up to 40% in the small number compared to this in the high risk zone. So that's where this trend or pattern has come. So what I suggest, again, the jury is still out, not the rest of the world does it. Only Americans and Canadians do it, and a few European countries, that you do transcutaneous bili, all babies who look yellow to you, because eyes are not as good, just like our fetal monitor versus clinical exam. So it's very cheap, it takes a few minutes. Okay, so they concluded, again, I'm going to go quickly through it, I don't know. So their concern was because of that resurgence of Kernicterus there, right? These babies may be at a high risk for Kernicterus, so it cannot predict at low levels, but certainly if it is high, do not discharge the patients. And again, the baby should be followed up, and I'll present you some more data. And pediatricians should be vigilant about it. So those of us who worked in the lab, as I said earlier, bilirubin is a very unstable compound. That's why I tell you, if you collected a bili sample, please cover it, make sure it's done within half an hour, because this light even will photooxidize it or change it into different compound. One of the things I want to address in this slide is, as I said earlier, there's a lot of different compounds of bilirubin, different isomers of bilirubin. For instance, if you used phototherapy, you have converted part of that 99Z structure into the EE or EZ compound, which we call as lumibilirubin. It's classified under a separate group. So you're measuring that. That's water soluble. That's not toxic to the brain. So one has to be very careful. That's where the term vigintophobia was coined, that don't be afraid of a number, treat the patient. All right? So this is a fascinating, coming back to once we've looked at bilirubin, again in the interest of time I'm not going into details, you must get in the habit in a baby who's severely jaundice, you suspect hemolysis, to look at the morphological structures. On the extreme left you have different structures, I'll show you pictures, but let me concentrate on the commonest one in the interest of time. You have spherocytes, either you're dealing with ABO hemolytic disease or hereditary spherocytosis. How do you differentiate? Majority of the patients, you will, in hereditary spherocytosis, direct antibody test or Coombs test will be negative, whereas it will be positive in the ABO hemolytic disease. Okay? And again, if you look at the mean corpuscular volume in spherocyte, because the red cell membrane is defective, that those babies will have a higher MCHC in the hereditary spherocytosis as opposed to ABO hemolytic disease. So now let's look at the pictures themselves. Okay, pictures worth 1,000 words, and I always sometimes try to take you down to the heme lab to show you these pictures. In an ABO, you'll see a few microspherocytes. So what has happened here, that you see these red cell membrane is defective, the bipolar membrane of these cells, whereas in a hereditary, a lot of it is defective. Again, 75% of these babies, it's transmitted as an autosomal. So one of the things I always suggest to you, take 2 minutes to look at the mother's smear, or go ask the mother to go. She will have some amount of spherocytes in there. Again, I'm not going to go into the detail. If you have questions, you can ask me. Ovalocyte, or elliptical cells that are present. This is again rare. It's, as you know, it's normally seen in camels, those of you who are from Middle East. But again, there's a defect in the membrane there, and it can cause, and it happens because, as we know, red cells go through those capillaries, the membrane gets defective, and that's the reason you can sometimes get significant hemolysis in them. This is G6PD. We talked about it earlier, that here, as you can see, it's like Pac-Man is biting off that red cell membrane in here, and so you have a little hole there, and you do special training, and you see these classical textbook picture. Again, it's your board question, so read up on G6PD. Let me move on. Echinocytes, which you can see in pyruvate kinase. If you have these, it doesn't have to be there, but if you see these spicules are almost diagnostic of pyruvate kinase deficiency. And cystocytes, again, cystocytes not related to jaundice topic of mine today, but a baby with GIC, whatever is the underlying cause, sepsis, asphyxia, etc., hemolytic urine syndrome, you could get these helmet cells or other funny-looking cells in your peripheral smear. Okay, so and again, these are target cells, but again, you can get it in other conditions. I'll move on. So you as a doctor, this is the one of the AAP recommendations. If the baby is jaundiced, in the first 24 hours, you must do a transcutaneous total serum. If the baby is receiving phototherapy, you're crossing from the Botany zone from zone 2A to 2B, you should also do all these other tests. If some people, I personally feel that you must always do direct bilirubin because you cannot miss those diseases, and I'll show you a patient very soon. Total bilirubin concentration unresponsive to phototherapy, increase in direct bilirubin. Again, do these tests shown here. The recent studies have shown that serum albumin, although makes a lot of sense, doesn't really help us. Jaundice present after or prolonged jaundice, or if the baby is very sick, you want to investigate that for infection, cholestasis, hypothyroidism. I'm not going to talk about cholestasis at all. This slide looks a little complicated, but it's very simple. I'll try to make it simple. We already talked about this element. Bilirubin is bound to that, 99%. Transferred to the hepatocyte, gets conjugated. So this is what I teach you all always, is the law of mass action. It's true for any drug, many stuff you give. Bilirubin particularly is very tightly bound to the primary binding site. Those of you who know pharmacology or chemistry, we call it association constant. In other words, it's bound very tightly, 10 to the minus 7 moles per liter. But if you have a substance like sulfasalazine or certain antibiotics, it will bind at the same binding site on the primary binding site, it will displace it and you may get Kernicterus. So keep that in the back of your mind. So what happens? So 99% bound. Many of us in our younger days did research on unbound bilirubin. Whoops. So less than 1% is unbound, and that can cross over to the blood-brain barrier and one of the mechanisms of causing brain damage or damage to those lipid-rich brain cells of the nuclei. This is the resurgence of Kernicterus from the US registry, as you can see here. In the mid-90s, there was a peak, marked increase here. As we said earlier, the two reasons why it occurred. So what are the clinical findings? Again, as clinicians, we should know that. As I said, a lot of diseases in neonates can cause that. You can overlook, but if your baby is jaundiced, you must think of it. bilirubin high, absent marrow, but you can do brainstem evoked potential, EEGs, MRI, spectroscopy, and I will show you some MRI pictures, or some academic centers do free bilirubin measurements. The Japanese and the guys in Singapore do that quite a bit. The term has been recoined by clinician, acute cerebral encephalopathy. So if you got a baby who's doing this, you better do an exchange and get that bilirubin out by giving him albumin, doing an exchange. Otherwise, that baby will go on to develop what we call as a chronic bilirubin encephalopathy. And God help us, as we'll see at the end of my talk, because this particular agency has very high-powered lawyers, and I've had some of my ex-fellows who've got into trouble. Again, we talked about the terminology of this condition, pathological term, and the MRI is something new. You can get imaging of the MRI. This is a baby one of my colleagues in California had with a bilirubin almost 40 milligrams, symptoms we described earlier, lighting up the globus pallidus in the brain of the nucleus. So this is a routine test. It is done in addition to auditory brainstem evoked potential, where you are seeing abnormality of wave 5 and wave 7. So the AAP recommends, as you can see, which still holds today, if you're discharging baby early, you must follow it. But some babies, as I'll show you, can get into trouble between here. And this is the other recommendations. This is in this reference. You can look it up. Interesting paper I saw very recently, last year, that came out from England, or I forget, it's Australia, where they looked at babies discharged in the first 2 days, 3 to 4 days, greater than 5 days. The first 2 days is showed in the dark. Concentrate that. If there's a primi gravida, first baby, boom, see, look what happens here. The chance of readmission of that baby is much higher. Okay, so if you've got a primi gravida, especially if it's a borderline gestation, 36, 37 weeks of gestation, IDM, you have to keep in mind that that's a baby who may get into trouble. All right, prolonged jaundice, again, is a separate subject. I've just listed the different causes, and we can read it up. Most standard textbooks have that. Now, what are the therapeutic armamentarium available to us? Exchange transfusion. Those of us who've done thousands of this, we know that even in the older studies at Hopkins, there was a 1% or 2% complications, and these kids die. I've had my colleagues who've lost a baby. So you have to be very careful, and I'll give you an example if I have time later on. The hallmark of treatment today is phototherapy. There's a lot of debate amongst experts as to which kind of light. All I want you to take home in your message, what does it matter? Here's a slide that tells me what matters. Bilirubin is absorbed. The peak absorbance, those of you who know physics, is between 460 to 480 nanometers. And it's the blue spectrum or bluish-green spectrum that is absorbed. In terms, keep it simple, you have a baby, you want a light, the distance of the light from the baby, and the surface area you are irradiating is very important. And you must measure irradiance. There's two. When you're dealing with light, there are two things you look at. How bright, right? I'm not emitting any light, I'm just kidding. So the irradiance you have to measure. I have to repeatedly tell you in nursery, what's the irradiance? So you want, if your baby's bili is going up, you must come close to 30 microwatts per centimeter square per nanometer. Because the more you have, there's a dose-response relationship there, all right? So here's the recommendation of the American Academy of Pediatrics. Most of you can look it up in the AP guidelines. Some of it is old, but again, there is no science or evidence-based behind this. And this is something fascinating. Just came out a few months ago from some of my colleagues, including David, who is the vice chair at Stanford. They were doing studies in Africa where, you don't have this. They took sunlight, and they have used these little fancy things. They have blocked off the UV light. Does any medical student want to tell me, why do you block UV lights? Bad for you, right? Even for you, right? So you must. So there must be a plexiglass, something that's blocking the short and long UV lights. You want to only concentrate between that 460 to 480 or 490 nanometers. So moving on in the interest of time, the other therapies that have been around, old days we used to use phenobarb. The Japanese, the Asians have used that. Jerry used agar. Hemox, this is on my tin man in the very first picture. Here it is. It has been widely used in G6PD, ABO hemolytic disease, and have avoided exchange. The current recommendation is where? Anybody? And again, some of you may be laughing at phenobarb. Where is phenobarb, the drug of choice? Your board question. Hello, 30 years? Criggler-Najjar Type II, right? Where there's a partial deficiency of glucuronidase transferase. And if they don't respond to that, then you can get on a compassionate basis, the company will give you free of charge, okay, zinc or 10-protoporphyrin. RH, hemolytics or ABO, you can give intravenous immunoglobulin because it binds to the that's the current theory, it binds to the FC receptors, and here's the dose. So, quiz for you. Keep this in the back of your mind because I've got just bare enough time. This is a baby one of my ex-fellows had, a set of twins. 23-year-old mother, as you know, early discharge, unfortunately happened on Friday night evening. Term baby, on Saturday, the young mother noticed poor feeding. Her aunt was a nursing aide. She said, oh, don't worry about it. Baby gets on Sunday, lethargic, comes back to the hospital with a bilirubin 40, and lo and behold, dies. And I told him, thank the good Lord, your baby died. And I'll come back to that. Not that I'm cruel, but you will understand in a moment. Twin B, same thing happens. Pay attention. This is twins. Same thing happens. High bilirubin, this baby lives. And he called me a few weeks ago to wish me a happy new year, and I'm still standing vertical here. Thank you. So the question for you, gentlemen and ladies, is what is the diagnosis? How would you have managed? And as he called me a few weeks ago, he told me the baby died 3 years ago. So I want you to think of the diagnosis. The other kid, maybe Diana and Dr. Bienvenue and Kathy, remember we had this baby several years ago. No relevant history, 3 days, baby's breastfed along with a little bit of body, no blood group incompatibility, no significant hemolysis. Here's the bilirubin levels. Keep that in the back of your mind. Our clinic test was positive, clinic sticks was negative. So she had consulted me. I thought maybe it's galactosemia. So we changed the formula, put him on phototherapy, bili came down with discharge, but the mother was from Alexandria. I had a wonderful young pediatrician, and I said, call me with this problem. The guy went on leave, his nurse saw him. When he came back, he said, Dr. P, the bilirubin is high, so we readmitted. I want you to keep those numbers in the back of your mind. Tell me what is the diagnosis and how you would manage it. Again, as I said earlier, in these rare cases, if you don't pick up the diagnosis early, you are going to get into trouble. Okay, so I am going to show you a few, this is a very important part of my presentation. So let me see what I do here. So sit back and relax, hopefully it'll open up. Parents' perspective. This is chronic bilirubin encephalopathy.
Kernicterus is a serious problem where otherwise normal children can suffer lifelong neurologic consequences. It shouldn't happen.
This is a condition that actually is totally preventable if children or infants that have jaundice can be identified and then treated appropriately.
I always say this, I don't think the human language can do a very good job of explaining the depth of disability that these kids live with.
No one can get Kernicterus. Kernicterus basically ruins your life.
And it's heartbreaking. I mean, we have children here who are not mentally retarded. They're not cognitively impaired by this disease at all. And yet they're locked in bodies that just don't work. And they're going to lead very, very challenging lives.
It's like if you're to tie your hands, your feet together, put cotton in your ears, gag your mouth, and then live your life. That's sort of what Krista faces each day.
60% of newborns do have some level of jaundice. The jaundice is an expression of an elevated bilirubin level, and bilirubin in newborns is a toxin and should be recognized as such.
Let moms and dads know that their babies can be hurt by jaundice. It's not like a rash. It's not like a common cold. This has injured our kids permanently.
The fact that that infants are not routinely tested for this toxin is difficult to understand, especially when one recognizes that the test is available, relatively easy to perform, and inexpensive.
This is something that we ought to be able to avoid. And we do have the capability of avoiding that by screening babies before they go home from the hospital.
We know about jaundice. We know what causes Kernicterus. And we know that if we get the right tests and the right treatments, we can prevent this.
I think the most important thing to remember behind this is these are innocent children. These children had just as much chance as everyone else. And we're not given that opportunity.
And now I watched my daughter and my son, who had the same blood incompatibility. One got a test, one didn't. And I watched them play side by side with two incredibly different futures.
This is an emergency. Babies are being injured. And, while we're sitting here talking about this, it's happening again.
I gave a talk to the Child Neurology Society, and these are the pediatricians who are neurologists like myself. And I asked for a show of hands of how many had seen a Kernicterus. This was in October 2002, and almost every hand went up in the audience.
So within a very short period of time, the moms and the doctors were actually connecting the dots and recognizing that this wasn't just, these weren't outliers in the healthcare system, this was a major hole in the safety net in healthcare. It's chilling to experience the healthcare system not reacting quickly to this, not implementing a universal screen. It's confusing and really disappointing. But that's why PIC has chosen to partner with the system to fast-track change.
Children who are discharged from the nursery should all have a bilirubin level taken at the time of discharge to establish whether they are at risk or not.
There's absolutely no reason why this is not universally practiced in the U.S. to ensure that every newborn baby has a safe experience with newborn jaundice.
We're of the opinion that because Kernicterus is a preventable disorder, that one case is one case too many.
One case of Kernicterus is one too many. We can prevent them all.
Prevent this. 2 words, prevent this.
So the few messages I want to leave with you today is try to promote breastfeeding, or once the bilirubin comes 20 milligram or greater, watch it carefully. Don't be afraid. That number came from Rh disease, and depending on what day, how old is that baby, you can always make sure he's well hydrated. As I said, the treatment is frequent breastfeeding. Make sure you remember all the causes I listed earlier, what rules out physiological jaundice. Follow up. Whenever in doubt, bring the baby back, and if they don't come, you follow it up. Again, thing I see all the time. Jaundice is not equal to phototherapy. If you are worried enough to give phototherapy, you must investigate. And these are the basic tests: direct therapy accordingly and early. Transfer. This is very important. And one of the cases I presented from my ex-fellow, that you must send, because nowadays I've had the last few generations of fellows we have graduated had never done a single exchange transfusion. So it is not a benign procedure. You have to have right type of blood bank, right mixing of the O negative AB plasma. And as I said, those of us who have done thousands have witnessed where babies have died during the procedure. So you as a practicing doctor must transfer to a center that is experienced, again, in doing it. Moving on, come back to my quiz number 1. Any takers? Sarah, anybody? I won't put any names other than Sarah's, no. Guess it, yours. Remember, the mother. So what is the diagnosis here? This is the baby that was born in our hospital. What is it that strikes you? Remember what I said right at the beginning? And I talk a lot, some you may have noticed, I'm just kidding. That it strikes you, which we may have overlooked. We thought, well, there's too much load. So the excretion part, the other part, faucet and the drainage part, we attributed it to that. And we got burned by this, which all of us were taught as residents or fellows, that if you have plenty, it's not. because as we know, there's false positive, false negative. You have to do enzymes to diagnose galactose. And when we did, when the results came back, it was negative. We sent it to Minnesota. But what this pediatrician called me is, look at that. You got 6 milligram per deciliter. That's your hint. Come on, guys. I always tell you, I'm not going to talk about conjugated bili today, but the most important cause you cannot afford to miss is biliary atresia, especially extrahepatic. Any pediatric surgeon will tell you that they would rather do a Kasai procedure early on. And thank God Dr. Brown did it in this case, and the baby is doing extremely well. The second case which my fellow had was a set of twins. Both are dying of Kernicterus. When he called me a few weeks ago, I asked him what happened to the other kid. And I told him, you're lucky the kid died. He died at 3.5 years of age, had an abnormal ABR, because you saw the video with, have you all noticed that there was PIC? You know what the acronym PIC stands for? Parents of Infants and Children Against Kernicterus. These are the ones, guys, it's a big organization based out of North Carolina, where they have high-powered lawyers. If you got a kid with Kernicterus, you can kiss it goodbye in terms of malpractice, because they will call them. It's all available on the web and the YouTube, as you saw. All right. So the diagnosis. I asked him what's the diagnosis, because he had sent the second kid to Texas Children's Hospital, and I don't agree with the diagnosis. He thought it was Lucy Driscoll. I personally think it's Criggler-Najjar Type I, and which was picked up in the video, as you saw. The mother had a set of twins too. The second twin was fine, and I'm told that kiddo got a liver transplant. But anyway, so that is the diagnosis, and there are different managements of that. So keep that in the back of your minds. Try to do all this, and I will open up for any questions. He's the reason for me to live, my grandkid. Thank you, guys. And any questions? No?
Thank you so much. This is very good. And I was wondering, what was the discharge bilirubin in case 2? Discharge bilirubin on day 2.
The discharge bilirubin was, I don't remember the exact numbers. He told me it was in the teens. He had already done an exchange, several exchanges, in fact, in that kiddo, and it had come down. But again, what point I'm making with the case 2 is that our healthcare system is fragmented. The same doctor taking care of it in the nursery. That's one of the reasons it was missed. They didn't want to go in and wait in the emergency room. He discharged on Friday. They were waiting for the pediatrician who happened to be away in town, but it happened so fast. It's very, very rare, but it can happen in the real world. So the point or the message there, please follow it up closely. Yes, sir.
Just a couple of points of clarification. The health economic dictates early discharge.
See, first thing going is my hearing. Say that louder.
Health economics dictates early discharge.
Right.
The early discharge doesn't cause Kernicterus or any other problem.
Nobody's saying that.
The important thing is the follow-up.
Right.
So if you, and Dr. Bivenu has a nice arrangement that for the kids that you have any doubts of jaundice, you bring back next morning for a bili check. And at the same time, you can look at the babies clinically and reevaluate what little tests they have. They got ABO, is the primary thing that you look at, and look at the clinical judgment. So there shouldn't be any, and when you do, and Transcutaneous now freely available, just do it, and look at the chart compared to the age of the baby in hours, not in days. So if it's in high risk, if in doubt, talk to your attending. That's all you have to do. But in the meantime, look at the baby, look at the basic tests, and do a transcutaneous. And there's no magic number. They have to stay in hospital for an extra day because it'll be over 10, because you got to put in perspective.
Thank you. That's why I said pigeontophobia. Treat the patient, not a number. Okay. Anybody else? Any other question? Thank you. Others will call it a